Welcome everybody to this week's acid-base conference. I'm going to start off with a 23-year-old female, G2P1A0, who was admitted at 32 weeks gestation because of hypokalemia that was resistant to treatment. As far as her past medical history, she had labor induced at 37 weeks gestation. Her potassium was always in that range, 2.6 to 3.4, depending on treatment. And she also was hypertensive. And her potassium normalized after her pregnancy. And on physical, her blood pressure was 131 over 81. So my first question to you is not an acid-base question, but is this hypertensive for the third trimester of pregnancy or normotensive? Does anyone know what the normal blood pressure should be in the third trimester? Okay, well, this chart shows the changes, and this is obviously population norms. It's a nice article referenced at the bottom there. But after 28 weeks, the blood pressure should be about 121 over 80. So she had some systolic hypertension. Okay, so what about the rest of the workup? So blood and urines, or sodium, looking at the left, the sodium was 136, potassium was 2.5. The chloride was 103, her total CO2 was 24, BUN 5, creatinine 0.7. And her blood gases showed a pH of 7.44, PCO2 of 38, and a bicarb of 25. Her magnesium was about 1.5. The normal magnesium, you have to always ask what is it in the third trimester of pregnancy. It's normally 1.1 to 2.2, not much different than normal. The calcium was 8.3. There you see beside it on the right, the normal range. Of note, her aldosterone was less than 3. And in the third trimester of pregnancy, it's about 60. So it's higher than it is normally. And the renin in the third trimester is normally 14, and hers was 2.7. So she was hyporenin, hypoaldo. And she remained, but she was hypokalemic. And despite being on potassium chloride and getting mag supplements, but she was induced at 37 weeks, and the abnormalities resolved postpartum. All her electrolyte abnormalities resolved. And as far as the urine, her fractional excretion of potassium was 33. The normal fractional excretion is about 8%. And we calculate the fractional excretion of potassium like we do for sodium or any other substance. And for those of you that don't remember, just after the talk, ask me for the formula. But the fractional excretion of anything refers conceptually to it's a ratio of the amount excreted in the urine over a period of time divided by the amount filtered. And the nice thing about it is you don't need to get a timed collection to get that result, but it assumes when you don't get the time collection that the fractional excretion is the same no matter what time frame you get it over. So, and that's really a separate topic, how to assess fractional excretion and conceptually and physiologically what it means. But we use the fractional excretion independent of the timed collection or a urine potassium over creatinine. It's actually, it gives you more information than just a spot potassium or a potassium to creatinine ratio. And we can talk about that offline for those of you that aren't that familiar with those concepts. So she had a high fractional excretion of potassium, which means somewhere in the nephron, she was absorbing less potassium than normal, because the normal, or you can look at it conversely, that her fractional reabsorption was 67%. Normally it should be 92%, which means 92% of the filtered load should be absorbed by the nephron. It doesn't tell you where in the nephron, it just tells you the total absorption relative to the filtered load. And hers was less than normal, telling you that somewhere in the nephron, she's absorbing less potassium than she should be. So the first question is there an acid-base abnormality? Her PCO2 looks pretty normal. Her bicarbonate looks normal. And the pH looks pretty normal. Does anyone have any thoughts about that? Don't be afraid. Jump into the water. Nobody? Okay. Well, the question then, what should the acid-base values be? If you compared it to the normal population, you would say there's nothing going on here. But the trick, if this was a board question, is that the numbers that you get in the third trimester and actually throughout pregnancy are not normal numbers. What acid-base abnormality do you get during pregnancy? And it's not an abnormality, it's what you get in all normal pregnancies. Does anybody know what the acid-base abnormality is in all women who have a normal pregnancy? Anybody?
Sometimes you can have respiratory alkalosis.
Okay, you always get it. It's not, yes, that's correct. But the point is that if you don't get it, you have something abnormal going on. And you'll see in this patient that there is more than just one acid-base disorder, but you always get a respiratory alkalosis in pregnancy. So the point is, if you don't, so it's a chronic respiratory alkalosis because it's not just for a minute or two or an hour or two, it's throughout the entire pregnancy. And if you look at, this is a nice paper from the 70s. This phenomenon has been known for some time, but if you just look at the 3 trimesters, represented here by 12 weeks, 24 weeks, and 38 weeks, these are representative of a large number of women, the average values. And you can see that even by the first trimester, the PCO2 has already fallen to 30. And it's pretty constant. It doesn't really change much. The bicarbonate falls as you would predict for a chronic respiratory alkalosis. Remember, for every 10 fall in the PCO2, the bicarbonate falls half of that. So the ratio is 2 to 1. And you can see it's about that. And it doesn't really change throughout pregnancy. The numbers stay pretty constant. So again, all normal women have a chronic respiratory alkalosis during pregnancy. And if you don't see that, like our patient here, you have to immediately think there's something wrong. Don't be fooled and compare these numbers to what you would get when you're not pregnant. And that's the trick here, that you would first say, well, these are normal numbers, but they're not. There's something going on. So let's delve into this a little further. Again, in all patients with chronic respiratory alkalosis, whether it's a end-stage liver disease patient or someone who lives at high altitude or women when they're pregnant, you get this initial fall in the bicarbonate when the PCO2 drops acutely. So the experiment here is drop the PCO2 from its original level and keep it at that new level. The bicarbonate falls initially, remember, because of the bicarbonate buffer reaction, but then it continues to fall to a new steady state level. Even though the PCO2 isn't continually changing, it's fallen and it stays there. Bicarbonate falls to a new level. And when you look at the change from normality of the bicarbonate and you look at the change from normality of the PCO2 in millimeters of mercury falls twice or changes twice compared to what the bicarbonate changed by in milliequivalents per liter. So 2 to 1. There's no units shown here, but if you see 2 to 1, that's chronic respiratory alkalosis. But what is going on with our patient? First of all, we don't see any change from normality. We see something like this. We would expect this to be occurring, but something is preventing our patient's bicarbonate from changing. It's 25 and the PCO2 looks normal. So let's think of this now a little more analytically. Again, we have these kind of numbers which look normal, but the question then becomes, how did we get from these kind of numbers, 30 and 19, back to 38 and 25? So that's the trick here. That's what you have to figure out. Well, when you do all the thinking, and I'll show in a minute, there's got to be 3 acid-base disorders. We know there must be a chronic respiratory alkalosis, or we intuit that there must be. We don't have the data if she was normal. But there's something raised in the bicarbonate, and given the hypokalemia and given the high fractional excretion of potassium, and given the low renin and the low aldo, we'll talk about what must be going on in a minute. The acid-base disorder that's most compatible with those findings is a metabolic alkalosis. Again, we're guessing because we don't have things as far as a movie temporally with time. And she was given potassium chloride and nothing changed. So we don't have the urine chloride, but we would guess that it's chloride resistant. And she was hypertensive. So the hypertension with the lack of the phenomenology changing with chloride being given as far as therapeutically suggests that it's chloride resistant. And I'll show you why she must also have a respiratory acidosis. So we'll break things up. Let's start at the 38th week, assuming she was a normal female. She would have, and again, we have to assume population means because we don't know what her numbers were, but assuming that she falls within the normal population, her PCO2 would have been around 30 and the bicarbonate around 23. Now, with the addition of the metabolic alkalosis, raising the bicarbonate from 20 to what we would think initially would be normal, but is not normal for her, it should be 20. Her PCO2 should be 32 because remember, there's a compensation with a metabolic alkalosis of about 0.7 times whatever the bicarbonate goes up by. So if the bicarbonate went up by, let's say, 4.7, you would predict if you multiply 70% of 4.7 that the PCO2 would have gone up to 32.7. But it didn't go up to 32.7, it went up to 38. So she is hypoventilating more than you would predict just as a compensation for a metabolic acidosis. In other words, her PCO2 should have been 32 and it's higher than that. So by definition, if the ventilation is less than you would predict, she should hypoventilate. Her PCO2 should be 32.7 as a compensation for the metabolic alkalosis, but her hypoventilation is greater than what we would predict, which means she must also have a respiratory acidosis. So this person has 3 acid-base disorders that return her numbers to what look like normal numbers. So it's an interesting case in that sense. So she has 3 simultaneous acid-base disorders normalizing her numbers. Okay, let's go a little further. What are all the findings in this patient? She has hypokalemia, she's hypertensive, she looks like she has a chloride-resistant metabolic alkalosis, or to know for sure we would get a urine chloride and find that it would be normal. And she has a low aldo and a low renin. Now, normally people think of hyporenin, hypoaldo with a non-GAP metabolic acidosis and hyperkalemia. So does anyone know what all this phenomenology represents? Low aldo, low renin, metabolic alkalosis with a chloride-resistant metabolic alkalosis and hypertension. What is the sort of general category of these findings? Does anyone have an idea? So what is the syndrome called? Well, this is called pseudo-hyperaldosteronism. It looks like the patient's hyperaldo. She's hypertensive, she has a metabolic alkalosis, she's hypokalemic, but her aldo is low. That's why it's called pseudo. So hopefully you'll learn in your fellowship, there are many, many causes for this, and I'll go over a few today, and we'll do the rest next time, but this will definitely be on your boards. So there's a whole number of diseases that can lead to this sort of general pattern of findings. There's something called Geller syndrome, which we'll talk about. AME, or apparent mineralocorticoid excess. Cushing syndrome or disease. Crusoe syndrome. GRA, or glucocorticoid remedial aldosteronism. Little syndrome, and congenital adrenal hyperplasia, and there's a few causes of that. So does anyone know what our patient most likely has? The clue is that all this went away after she gave birth. Anybody? Okay. Well, she has a disease called Geller syndrome, and it was described 2000, and it's due to an activating mutation in the mineralocorticoid receptor, and it's exacerbated when you're pregnant, and we'll go into why that is. So first you have to know where the mineralocorticoid receptor is. Prior to that, you have to know all the segments of the nephron, and hopefully during your fellowship, you'll expand your understanding of the nephron so that you won't say or divide the nephron up like you do as a medical student or a resident into proximal or distal. There's about 15 or 20 different segments in the nephron that you really should know. They have totally different transport functions, and you really can't understand all the diseases in the nephron that affect all the electrolytes unless you first know the anatomy. So after the thick ascending limb, the cortical thick ascending limb, there's a segment called the distal convoluted tubule. This is where thiazides work, and that's where amiloride works in part, Gittleman syndrome. So there's mineralocorticoid receptors here. It's called the distal convoluted tubule because, like the proximal tubule, it's convoluted when you look at it. And then after the distal convoluted tubule is another segment called the connecting tubule. And then after that is another segment called the cortical collecting duct. These are the three segments where the mineralocorticoid receptor is found in the nephron. Now, the mineralocorticoid receptor is a membrane protein with what are called transmembrane alpha helices, which are parts of the protein that weave in and out of the plasma membrane. And there's 12 helices, and aldosterone, shown here in this little yellow in the middle here, it's sort of hard to see, interacts with the receptor in certain helices. Aldosterone is the physiologic ligand for the mineralocorticoid receptor. Now, when aldosterone binds to its receptor, the receptor is internalized and then goes to the nucleus, where it binds to the DNA that codes for different proteins, including different transporters that are listed here. It stimulates the sodium channel called ENaC. It stimulates the ROMK potassium channel. We won't go into any of this today, but its downstream effects on the tubule segments that are shown where the receptor is depend on whether it increases or decreases or has no effect on various transporters. Remember, we have 24,000 genes or so, and this only shows some of the genes that are modulated by aldosterone. They happen to be involved in the pathogenesis of metabolic alkalosis, which is a complex set of events that occurs that we won't get into today. But these are just some of the protein, the transporters that are changed. This is the proton potassium ATPase, and then AE1 is a chloride bicarbonate exchanger on the basolateral membrane of alpha intercalated cells. So aldosterone has effects on all of these that leads to the sort of global clinical changes in the blood chemistries that we measure. We won't get into it today, but just so you are recognizing the proteins that are involved. Okay, so what happens in Geller syndrome? Well, first of all, steroids like aldosterone with 21 hydroxyl groups are the ones that interact with the mineralocorticoid receptor. So aldosterone has a 21 hydroxyl groups. Progesterone doesn't, so it doesn't normally bind. So that's the first thing to remember. And in these patients, they have a serine 810 to leucine mutation in the mineralocorticoid receptor. It's autosomal dominant. You only need one allele mutated, and it's an activating mutation, not an inhibiting mutation. So aldosterone, it turns out, works normally in these patients, but there's constitutive activation at about 27% maximal activity, even without aldosterone present. So that's the first abnormality. You're not supposed to have activation of the receptor when the ligand isn't there, but these receptors are activated all the time. And the second thing that occurs is progesterone, because of the mutation, is able to interact and activate the receptor. And the key point is that progesterone increases during pregnancy, but its concentration is about 100-fold greater than normal in the third trimester. So you get this abnormal activation of the mineralocorticoid receptor in patients with this mutation. Interestingly, as an aside, and it's important to know therapeutically, is unlike the wild type receptor, aldosterone or aldactone actually activates the mineralocorticoid receptor, and a lot of MDs who treat these patients give them aldactone by mistake, well, they think that they're going to inhibit the phenomenology. They actually make it worse. So you cannot use spironolactone in these patients. And it also can result in abnormalities in males. And the reason is the constitutive activation that I mentioned. Even without aldosterone, the receptor has activity above normality. And secondly, males produce 17-hydroxyprogesterone normally. And 17-hydroxyprogesterone can also interact with the receptor. So you can see this in some males too. But in general, it's a phenomenon in pregnant females with a mutation. And the point is it goes away after birth because the progesterone level just drops down significantly. Now, there's another entity called apparent mineralocorticoid excess, and that's due to mutations in an enzyme called 11-beta-hydroxysteroid dehydrogenase 2. Now, to understand what's going on here, you have to think of a cycle. There's and this occurs in glucocorticoid receptor-rich tissues, shown above in purple, and mineralocorticoid receptor-rich tissues like the kidney, colon, and salivary glands. So what are there's two enzymes in the cycle. The D1 variant, or the first variant, and the second variant. They're slightly different in their sequence. One enzyme in the glucocorticoid-rich, receptor-rich tissues converts cortisone, which is inactive, to the active compound cortisol, which we're all familiar with. And then cortisol binds to the glucocorticoid receptor in these tissues. In the kidney, cortisol is converted back into cortisone so that cortisol doesn't increase too greatly. And the reason for that is because cortisol has the same affinity to the mineralocorticoid receptor in those 3 nephron segments as aldosterone does, except that the concentration of cortisol is 1,000 times higher. So the kidney has this enzyme, the type 2 variant, that makes sure that cortisol doesn't increase sufficiently to totally swamp the mineralocorticoid receptor. But in the absence of this enzyme, in this case, due to mutations that the child is born with, you don't have a functioning enzyme, and cortisol builds up like crazy, binds to the mineralocorticoid receptor, and basically the tubule doesn't know there's no aldosterone around. It has the same downstream effects and leads to everything that we would predict, as we'll show in a minute. So this is caused by too much cortisol being present because you lack functional enzyme to convert the cortisol back to cortisone. So the clinical features are it's autosomal recessive, unlike Geller syndrome, and you get it in kids because they're born with a mutation. They have hypokalemia, a chloride-resistant metabolic alkalosis. They're hypertensive. They also have hypercalciuria, nephrocalcinosis, and they can get CKD also. The diagnosis is made by just measuring the urine-free cortisol to cortisone. As I said, if with the normal enzyme, the cortisol is back converted to cortisone. But in these cases, you have a much higher ratio than normal is 0.3 to 0.5. You have roughly 50% as much cortisol than cortisone with a normal kidney or the wild type enzyme. But in the absence of this enzyme, this ratio can go sky high. Diagnosis is made by genetic testing, and as you might intuit, you can block the abnormal physiology with mineralocorticoid receptor blockers so that the excess cortisol doesn't bind, or you can block ENaC with amiloride or triamterene. Some people also try giving exogenous glucocorticoids, which you might think is counterintuitive, to suppress the cortisol that the tubule's seeing. Now, you can also get AME acquired from having too much licorice ingestion. Licorice, as you know, or you might remember, comes from a root. But the issue is that licorice contains glyceric acid, and it's hydrolyzed by bacteria in the intestine to glycyrrhetinic acid. And glycyrrhetinic acid inhibits this enzyme. So it's similar, you have an acquired form of the problem. A safe upper limit for licorice is about 100 milligrams a day. Now, in licorice produced in the US, it's usually absent from licorice. But if the licorice is mixed with chewing tobacco has the glycyrrhetinic acid, or you get it imported, you can also inhibit the enzyme. It's also found in anise-flavored liquor that many people in many countries ingest. So you have to be aware of that too. It might not be coming from licorice. Anise comes from a plant, and it gives a sweet flavor to the liquor. And carbonoxolone is a derivative of glycyrrhetinic acid, and it's used often as an antacid, either orally in the mouth for mouth ulcers or for gastric ulcers. There are also antifungal agents that can block the enzyme mentioned here, itraconazole and posaconazole. This is another acquired form of apparent mineralocorticoid excess. And the diagnosis, again, is increased cortisol to cortisone ratio, either in the serum or the urine. And the treatment, as I mentioned before, are mineralocorticoid receptor blockers or blocking ENaC. I mean, the best thing is just to stop the ingestion of these things. Does anybody have any questions about that? Cushing syndrome is similar. Cushing syndrome is an excess cortisol. Basically, you have so much cortisol being produced that you swamp the 11-beta hydroxysteroid dehydrogenase 2, the orange enzyme. Even though the enzyme functions normally, there's just so much cortisol around that you can't convert all of it to cortisone. There's nothing wrong with the enzyme. There's a limit to how much it can convert back to cortisone. And so again, you end up with too much cortisol binding the mineralocorticoid receptor in those nephron segments, leading to the same thing. So you can have too much cortisol because this enzyme doesn't work, as I showed, either congenitally or acquired, or you can have so much cortisol produced that even though you have a normal enzyme, you still have the problem. Then there's another disease called Krusa syndrome, and this was described in '82, and it's felt to now be due to a mutation in the glucocorticoid receptor. So if you just think of what might be occurring, on the left is sort of the normal pathway where CRH in the hypothalamus makes ACTH, and you get cortisol, androgens, and deoxycorticosterone and corticosterone made. So this is what happens in these patients who have a congenital mutation in the glucocorticoid receptor. Basically, you can't get cortisol binding to the glucocorticoid receptor, and you get excess CRH, excess ACTH, and everything is increased. And they don't just have phenomenology of Cushing's disease. They also get abnormalities on the mineralocorticoid side, and also they get increased androgens just because it's occurring likely congenitally or even in utero. So they can have complex phenomenology. They get the hypertension, hypokalemic metabolic alkalosis, cortisol is increased, so they get what looks like Cushing disease. And they also have, because there's excess androgens, ambiguous genitalia, they're viralized, all these other things occur also. So complex and easy to see as far as their phenotype compared to the other diseases we've just talked about. So this is autosomal dominant again. You only need one allele mutated. This is again the glucocorticoid receptor. It's a pediatric disease, but if they get to adulthood, you might see them. They're hypertensive again, hypokalemic with a chloride-resistant metabolic alkalosis, and they're viralized. Diagnosis, they have increased serum or urinary free cortisol. They also have an abnormal dexamethasone suppression test. So remember, there's sort of the short test or the longer test. You can give a milligram. We can go over the test if you want, but a typical test would be to give a milligram of dexamethasone, and the next morning the cortisol should be less than around 1.8 micrograms per deciliter. Or some people measure it the morning before the dexamethasone is given, and then the next morning the cortisol should fall by 50%. And this is abnormal because they have an abnormal receptor, so ACTH just stays high and isn't suppressed. You can also send the glucocorticoid receptor off for a genetic analysis or mutational analysis. And again, same sort of thing. You don't treat the cause, you're treating the end result by either mineralocorticoid receptor blockers or ENaC blockade. Some people give high dose dexamethasone, even though it doesn't suppress totally, in an attempt to suppress ACTH. And therefore, again, if you get it early enough, you'll be suppressing the excess androgen phenomenology and also mineralocorticoid excess in addition to suppressing cortisol. So I think there's a whole range of other diseases that were shown in this initial slide, but I think I'll stop there and we'll continue next week discussing in greater detail the remaining diseases that cause pseudohyperaldosteronism. So I think we'll stop there for today. And if you could start reading on those diseases, you'll definitely come across this in your fellowship and your career. It's really important to understand the differential diagnosis and approach to this form of chloride-resistant metabolic alkalosis, but associated with hyporenal and hypoaldo. So not what we typically think of in a patient with hyporenal and hypoaldo. So does anyone have any questions about what we talked about today?